Welcome to a conversation about Black women and HIV. We're here in Boston, Massachusetts, as part of the CROI conference that's happening, and I have the lovely opportunity to sit here and talk with three beautiful women who's doing work in HIV and AIDS, specifically focusing on addressing the HIV epidemic amongst Black women. So welcome, ladies.
Thank you.
Thank you.
So I want to take some time to do some introductions. But I want you, as part of your introduction, of course, give your name, what you do, the organization you work for, but also tell me a little bit about the community that you serve and the community that you're a part of.
Well, my name is Kim Wilson. I'm a senior peer advocate. I work in the, we call the Roxbury, the urban area of Boston. I work with a wide, diverse group of young ladies from ages 18 or younger up to the oldest, I think, is maybe 60, 70 years old. We work on a wide variety of health disparities they have. You know, I work with ladies getting them into healthcare, maintaining healthcare with them. I believe personally that being a lady, we should meet our basic needs. Yeah. And I see that a lot of the ladies I work with, that once I help them with their basic needs about housing, food, their children, because as ladies, you know, we think of ourselves secondly, and then we think of, you know, other things, you know. So I work with a lot of ladies I make sure that they have their housing is okay, you know, their relationships are okay with their children and their family, and then we go from there, from their house care to their health care. I work for the AIDS Action Committee of Massachusetts.
Thank you.
Hi, my name is Malkia Kendricks, and I work for Women Connecting Affecting Change. We are part of the MAC, the Multicultural AIDS Coalition. We started out as the Women of Color AIDS Council, but because of the stigma in communities of color, we have Women Connecting Affecting Change on our doors. We have a drop-in center where we serve a very diverse group of women, primarily African American, but we have a lot of women that were born outside the country that are now living here in Massachusetts. And most of the population that we serve are women that are substance abusers. They engage in prostitution and all of the other areas to take care of themselves. We have a lot of homeless women. We have a lot of women that couch surf. We have a high majority of women that have mental health issues. And so we work with them in trying to link them back to healthcare and mental and medical healthcare. But of course, that's a challenge when you have substance abuse and other issues on the table.
Okay. Wow, I'm so excited to be with y'all. I just have to say that. So I'm Dazon Dixon-Jallo, and I'm the founder and president of Sister Love Incorporated, and I'm in Atlanta, Georgia. We will be 25 years old this summer.
Congratulations.
Thank you. We are, we like to say that we're on a mission to eradicate the impacts of HIV and other reproductive health challenges on women and their families. And we do that through education, prevention, support services, research, and human rights advocacy, both at home and abroad to a lot of respects. We have 2 program offices in Atlanta, and we have a program office in South Africa. And we focus primarily on prevention interventions, delivering them by women, for women in communities. And then we expand on that to do a lot more around prevention science, prevention research and education, community literacy around research. And also we engage in testing and linkage to care services in the community and focus in on positive women's leadership. I mean, there's a role for people in general who are living with HIV, but even more specifically for women who are living with HIV, to literally seize this epidemic and take the lead on not just serving others, but also in advocating for the needs that we have, policy, funding, and all of the other issues. So I'm really excited to be here with CROI, and as I close out my introduction, I'm going to throw it back to you, my sister Chioma, and make sure you tell folks who you are as well.
Well, you said my name. Chioma Nnaji, and I also work at the Multicultural AIDS Coalition as a program director. One of the programs that I work with is called the Africans for Improved Access Program, where we primarily serve African immigrants and refugees. We also serve other Black immigrants, such as immigrants that come from the Caribbean, but our primary focus is African immigrants and refugees, and we've been around since about 2000. And the women that we see are mostly women who are married. We also see women who are undocumented, women who recently immigrated here, refugees coming from places like Somalia and other places that are coming into the state, individuals coming into the state. And it's very interesting. So one of the things I always like to talk about is the diversity that we have with Black women and how we continue to lump Black women in this one category. But there's so many differences, and Malkia and I have the opportunity to be in one organization that serves this sort of diversity, and we see within African women the epidemic looks very much different, right? Very much different in terms of transmission. Heterosexual sex is the main mode of transmission. In terms of women getting infected who are married. In terms of women dealing with sort of what we call transnational issues, right? So whether their husbands or their partners are going back and forth, or whether they are going back and forth, and how does that impact their ability to provide for themselves? So like you talked about, sort of our priorities in life, but also how does that impact their HIV risk? So it's good that we have a diverse group sitting here at the table that serves a diverse group of women. One of the things that I want us to talk about is really about where do we see the epidemic is currently with Black women. And I want us to reflect on that as it relates to the HIV continuum, care continuum, right? And so the HIV care continuum has 5 parts to it, right? Testing is one. After testing, engagement in care, linkage to care. And then retention and care, right? And then being put on medication, and then being put on medication long enough so it's undetectable, right? So that the virus is undetectable. So with the communities that you serve and the communities that you're a part of, where do you see as some of the challenges we have across that HIV care continuum?
I can speak to that. We, most of the women that we serve aren't in care. Substance abuse is the first priority. With underlying mental health issues. And so a lot of the women can't get past that in order to actually get the medication or stay in care, or to even, some of them start taking medication, but they don't want other people to know about the medication, so they're hiding it or they lose it, all of that, or they don't have a permanent place to put it. We offer that they can keep their medication at WCAC so that they will have a place to put it. And some take advantage of that, but a lot of the women are so busy running, for the drugs that they can't really focus on HIV care. It's almost like that is not...
Survival is the focus.
Survival is definitely the focus. It's not HIV, and a lot of them know their status. A lot of them have been tested. We have many women that won't get tested because of their risk factors.
Sort of this understanding that, or fear that they will be
Yeah,
positive.
absolutely.
Yes,
Absolutely,
Yeah.
absolutely, because they know what they've been doing in the past and afraid that, they've been, and they're afraid that they are infected.
Right.
And, even though we talk about the continuum of care
Right.
and how wonderful the medications are today, and how you can become undetectable and not have a lower risk of passing that virus on to someone else. But it's just getting to that point, and it's a very difficult thing when you have mental illness and substance abuse, and then couch surfing, not a permanent place to stay. It's really tough.
Then also the fact that young ladies nowadays, ladies in general, the fact that if I know it, then this next guy I'm going to meet, I have to tell him.
Reject it.
Yeah,
That's another.
because I just had a group. I just had a group meet recently, and a lot of the ladies were like, "Well, we know our status, but what about this next guy?" You know what I mean? Because a lot of them depend on having somebody in their life to help them support. Will he reject me? And upon them getting rejected, they're like, "Well, I'd rather just sit by myself, not take any medicine, knowing that, hey, if I take this medicine, I'm gonna live a long life." Because like I do a lot of talking to ladies about, hey, you're only as good as your family's only as good as you are.
Yeah, that's
right.
You know what I mean? And if
As
you
healthy as
don't,
you are, yeah.
if you're the one who says, "Oh, I'm not going to do anything," and your health gets down to nothing, it's going to reflect on your family, and it's very hard for a lot of ladies to see that, and they'll lose everything, and then to the point of like, okay, I'm to the ground, and then they have to bring it back.
Well, I have to tell you, sometimes I even more than often lately, because I'm in Atlanta, Georgia, in the deep South, which is
It's a little
way
bit
more
different.
than
Oh, yes.
a geographical
Oh, yeah.
distinction,
Yeah,
right?
yeah. And
So
it's
I
a little bit
oftentimes sit with
different.
blue envy a lot of times in terms
Yeah.
of what services and what's
Yeah.
available to women in places like New York or here
Yeah.
in Boston.
Right.
It's very different
Right.
from what we face
Oh,
in the
yeah.
South, and
Yeah.
including just access to health care,
Yeah.
right? And so there are a lot of other issues that lean into or lead into the challenges around testing and getting linked to care. And a lot of that is actually legal, like around HIV criminalization, which is another reason that I may not want to know my status, because then
No.
I'm liable to disclose to partners, and that's a real big issue.
That is huge.
But disclosure itself has
a
a
huge-
huge role to play in the care continuum. So I'd say 3 real important things, especially for Black women in relationship to the care continuum. And that is one, that stigma and disclosure go together. So getting tested, linked to care, and then staying in care and getting on treatment and all of that are all connected to what people will know and when they know and what that means in my life.
Right.
But there's another part to it which we sort of use as a means to get women to that point, because there are lots of studies that show us about the science that for low income and no income women who are down and out and have nothing, an HIV status and HIV diagnosis and disclosure is actually a benefit.
You know, and
It's
that's
a
what I tell my
benefit in the
all
sense that
time.
they then can get access to services,
Yes.
even getting into
Yep.
treatment faster than they would if they weren't. And we use that actually. That for a lot of women, not necessarily middle class and upper income women, but for a lot of low and low income women, that disclosure means it opens up a financial door that you have been shut out from for a long time. And we actually use that as a means to
Makes sense.
And
encourage.
access to housing.
Yeah,
access
so
The
to
whole
Yes,
nine.
yeah.
Access
Yeah.
to housing, access to health care, getting your medication covered. Should you get pregnant, you will end up in a different level of care because of antenatal care that's specialized for women with HIV. So all of these things matter. The second thing, or maybe even third, I don't know, I might have covered 2 in there. But the other thing about the care continuum, no, there's a second. The other thing about the care continuum that I'm clear about is that in those first 2 columns, and this has been talked about a lot, but I think it's really special for women, is that when you're talking about getting tested and linked to care, most women are finding that out either when they're pregnant, right,
Yes, that's
or
right.
in
Yep.
community-based settings, because we're not getting tested when we go show up for contraception or family
Or
health,
even our primary care.
or even in our primary
Yeah.
care.
Yeah.
So the thing about that, though, is that most of those services are provided at the community level. It's once we link them into clinical care that they fall out. Stigma has a lot to do with that, how they're treated when they
With
get there,
providers,
Yep.
right?
what all of those barriers are to even get to that
Right.
regular visit on a regular basis, staying in care in terms of adherence. We know that there are many barriers to adherence, but my challenge with the care continuum is that the end point is viral suppression. And we know, especially for folks in the Black community, why viral suppression is important. One, it's important because you're going to live healthier and longer. And it's also important because we know now that people who are positive and suppress their virus are about 96% unlikely to transmit the virus. That's
Yep.
because of the science,
Yep.
right? My thing is that viral suppression cannot be the end point in that care continuum, especially for women, because I could be virally suppressed all day long, but if I'm still
got a place,
discriminated
right.
against, if I still don't have housing, if I still have mental health issues
Right,
and substance abuse problems.
Yeah, right.
So really the care continuum, we need to be looking at it for quality of life issues, why people are falling through those different columns. And then I bring back around that the care continuum is also not enough for us in our community, that we also need a prevention continuum.
Yes.
Because for everybody who shows up to get tested, right, in this country, even among Black people, only somewhere between maybe 1% and 5%. And that's if you're going really high into the epicenters, right? maybe somewhere between 1% and 5%, you're going to come back HIV positive. Well, what you going to do with the
other
95 to
5%,
98%
yep.
that are HIV negative?
Yep.
And got tested for a reason.
And
Yes,
thank
that-
you.
yeah.
And we're in an era where the science,
Yeah.
even what we just learned out of CROI today, that the science is showing us that we have biomedical options to help prevent HIV.
That is
But
correct.
people have to get tested, and they still have to get linked to something
Yeah.
in order to stay negative. And I think that that's not the message that's reaching most of the women in our community.
And I think, I mean, you brought up a very interesting point, because I think that we continue to leave out some of these social, cultural sort of structures and barriers, or they can even promote our HIV care, right? So when I think about, African immigrant, I definitely link it to immigration status, right?
Yes.
And so, fortunately here in Massachusetts, regardless of your immigration status, you can get HIV care, medication.
A lot of people
and
don't know that.
a lot of
NPS
one,
coming back.
I know,
yeah.
I know, and a lot. You're correct. A lot of people don't
don't
know
know
that,
Right.
and I think Massachusetts is a very special case in terms of we don't have even a waiting list for HDAP, which is different in a lot of other states.
Right.
It's very
And
Very.
so with one of the things that it sort of hurts me to say this, but one of the things that I think that we need to really focus on when we talk about immigrants is think about the impact of lifting the HIV ban, right? And so the HIV ban was lifted a couple years ago by President Obama. Which is good, right? So people living with HIV can come back and forth and don't have to feel as though they are criminals, right? Don't feel like they have to continue to go through some type of investigation when they cross the border.
Correct.
What the challenge is for us as HIV providers, I'm glad you brought up the position of CBOs, because we have grassroots organizations, we have resettlement organizations.
Right.
Even within my program, we work with civic organizations that are very particular to African countries or ethnic groups. And so when we look at the lifting of the HIV ban, we also have to talk about, okay, now how are we going to get folks tested?
Yes.
Right? So with the HIV ban, there was some measures around testing, even when people were here in the States, immigrants were here in the States and were trying to apply for citizenship, there was a level that they had to get tested for HIV as part of their medical exam, right? That's no longer a requirement. But now the question is, how are we going to get these individuals tested? Because, like you said, majority of folks, especially for immigrants, routine HIV testing is not a part of their year-to-year sort of care, right? They get tested because of someone they know, they get tested because of their partner, they get tested because one of us approached them and say, look, let's talk about this HIV thing. It's not because they go to the primary care physician and they request the HIV test.
Right.
See, I always feel, and I've said this for years, we test people for a zillion other things. Why isn't HIV one of the standard tests? They make it sound like it's something special.
And
You know what I
that
mean?
should be,
And it
because
should be a
Advent-
standard test
And I-
that
Well, I think
And I
people.
know that Massachusetts
Yeah.
is a little different. Thank you very much.
We try. We ain't perfect
But
now.
with the implementation and the advent and the implementation of the Affordable Care Act, for example,
Right.
HIV testing and counseling is now one of the 8 additional essential prevention
Yeah.
services that should
Right.
be delivered as free.
Right.
And what we now need to make sure is that every single provider who
Knows
is
that.
involved in the health exchanges and the marketplaces or in the Medicaid exchanges where it's actually happening, not in my state right now, but we're fighting and we're going to win,
Okay.
is that it should become a standard part of
It's
care because
normalized.
it's covered.
Right.
Because some people
Yeah.
think that when they get through all these standard testing, that HIV
It's
is
included.
already a part
Because
of
I
it.
just
When they take your
Yeah,
bloods,
yeah,
I got tested for
I
HIV.
talked to a lady recently, and she just found out, and she goes to me, "But I went to my doctor. I always go to my doctor." And she was,
they take blood all
and
the
she goes,
time.
they took all this blood, and
They didn't tell me I have HIV.
Yeah, and she was, they didn't tell me I had HIV, and the woman was sick. And the only reason why she came into my office was because somebody said, "You know what? I know this nice lady who can talk to you." And one of her friends who were HIV positive said, "Why don't you come in here and see if she can help you to find out this woman had HIV?" And I'm like, "Well, you went to your doctors," and she goes, "But they did all these tests on me, and people think. I mean, even myself as a young woman, I go to the doctors faithfully, and I'm notorious for the fact that I was linked to care late, very late. I was sick, almost in deathbed in the hospital, and all along, I just knew when I was through the years I've been sick that I had me giving an HIV test. And the last thing they gave me 2 days before I got diagnosed was this HIV test. And I'm sitting here sicker than a dog. And I always say, if you ought to taken a test as part of your standard, I would have never spent all this time in the hospital, been so sick as a person. And I always tell people, if you just done that test, I wouldn't have cost the insurance companies all this money and spend 6 months in the hospital sick, is sick in the dog on death's bed. But if you just done this test earlier, and the doctors have told me, we took every test possible. And then when they say that to me, as the layperson, I'm thinking, oh, an HIV test was included.
That's right.
And I'll be honest, for myself personally, it was a phlebotomist who said, let me do this one more test to find out 3 days later, oh, you have HIV. That's why you're so sick. And I'm sitting there going, but the man told me he did all these tests on this sheet. And I'm going, but that's not.
That's an excellent,
that's not
point.
one of the other. That's not one of the
That's an
tests.
excellent
And I consider myself a person who kept on saying, when going back to the doctor saying, I'll take a TB test. I was told I didn't have TB. I didn't have this. I didn't have that.
TB and HIV go hand in hand. But you know, I think that you're making up an excellent point in terms of the face of HIV for Black women is not the person on the corner. You know, a sex worker is not the person shot. You know, like. You know, we include our sisters who are struggling in those areas, but the face for HIV for Black women looks different. And so, you know, Black women walking into a community health center, or I wouldn't put grassroots because we know, but walking into a community health center or a hospital, you know, there's this perception that as long as she is not this, and this, then she can't have HIV.
Oh, I'm living proof of that. I mean, you know what I mean? I always say, you know, we have to look outside the box.
Which is why, and I'm sure from the work that you do, especially in substance use and mental health issues, which is why, and I've been sort of on this mantra for a few years, and I think we're finally sort of getting there in the AIDS community, because this is like almost 30 years of this work for me, right? And that is that while we could spend the first 25 plus years of the epidemic really lifting HIV out and making it an exceptional issue, because people literally were getting infected and dying very fast. That's not the case anymore. And the population that's now most infected in the United States and around the world are predominantly Black and brown. And our lives look very different just because, for no other reason than being Black and brown.
Come on now.
And we cannot afford to specialize in HIV anymore. Stigma for one, where and how we get our health care, how we relate to our healthcare settings and our providers, that if you don't put HIV in the broad mix of everything I've got going on, I just simply can't afford to make it a special thing. I can't afford to make it a special thing because there's stigma attached to it. I can't afford to make it a special thing because I got so many other prioritized challenges in my life. I can't afford to make it a special thing because the minute I do that, you're going to start stigmatizing my people, my community, my groups. So we've got to figure out a way. For example, I'm literally into now talking to Black women about viral health. Right? Because there's human papillomavirus, there's hepatitis C, and A, and B, and there's herpes, and there's all other kinds of things that impact our quality of life, of which HIV is still a threat, still a deadly threat, but it's still a part of the whole, because there are other deadly threats in our community, including violence. And okay, can I transition to that conversation for Black women?
You can do a little bit,
that even down to the science, even down to the science, that the role that trauma, lifetime, whether experienced as a child, as a preteen, as an adolescent, as an adult, that the role of trauma and violence play in our vulnerabilities and risks around HIV before and after an HIV diagnosis, right, are huge. I mean, it's almost 100% bidirectionally in effect. And we don't talk about that enough in terms of understanding how are we screening folks? You know, how are we screening folks when they come in for an HIV test for their experience with experiences with trauma and violence. And how is our domestic violence and violence against women's community identifying the HIV issues in the population that they serve?
Right.
And we are doing black women a disservice if we're not looking at the intersection for both. I don't know.
I like the way that you talked about how do we couch this conversation, because one of the things in working with African women, we're very clear about couching it within sexual health, because what we found is that, you know, we do, Malkia knows about what we call these safety net parties. And so it's basically, you know, Tupperware parties talking about sex, right? And so we have this opportunity to talk to women. And one of the things that comes out for African women is not even being clear. We can be frank, right? We're sisters having a couch conversation. All right. African women, and I'm saying this in a very general sense, but because of upbringing, because of stigma around talking about sex, stigma around talking about condoms, stigma around talking about intimate relationships, period. African women even questioning how many holes we have down there, right? Oh, do we urinate out of the same hole that we have sex, you know, that there's an insert that's happened.
I have to say that's not just African.
It's not, you say, so it's across the board. And so how do we have conversations that are
literacy around our bodies and our reproductive health in general. And that's why, and if you want to be real frank, when I got involved in this work, I came to this work through the feminist health movement, which meant I was one of the few very young, because I was crazy, very young, but intentionally so, black women who were traveling around, dropping my pants and showing my cervix and helping other people to see their own. You know, it used to be half speculum, will travel kind of thing, because if you don't know about your own body, then you're more likely to relinquish control of it to someone else, whether it's your partner or your doctor or anyone else. You're more likely to relinquish control of it if you don't know enough to own it.
So ladies, I want to shift the conversation a little bit, because we have, it is.
That body board that we
talk about body anatomy and so I want us to talk a little bit about promises, right? I mean, you know, looking towards the future, because it's not all dark for black women, right? You know, we know that there are things that are working for our communities, for the people that reflect who we are. And so let's talk a little bit about what we see happening within communities. We talked about the safety net parties. I think there is power, and like Dejan, what you were talking about, that Sister Love is doing, there's power in this peer-to-peer. There's power in women, black women, talking to black women about what we need to know and about coming together collectively to advocate. And I think there's models across the nation around that. But what else is happening in some of your organizations, or what you see out there that's very promising and that's going to really push the epidemic in a different way?
One of the curriculums that we do at WCAC is SISTA, Sisters Informing Sisters about topics on AIDS. And that particular workshop, of course, and I'm sure you guys are familiar with it, is specifically for women who don't know their status. And it actually helps them to open up and start talking about sex and how they talk to each other about women's health, how you talk to each other about violence, how you talk to each other about your partners. What is a healthy relationship? What does that really look like? Because if you are accustomed to being slapped around, yelled at, verbally abused, then you think that's a healthy relationship. That's what you've seen all of your life.
He only hits me once a week.
And I've had women, I've had women say that all the time. That that she's being verbally abused. He talks about how she looks and what her size, and she's too fat, she's too thin, her hair's too short, it's too long, it's this, it's that, everything. And you can see that she feels really bad about who she is as a person. Now, with her being torn down like that, of course she's open for everything else. Like, oh my God.
So, the reason I'm smiling with you is because it's one of these people who've been in this so long is Sister Love has a homegrown intervention called Healthy Love that preceded Sister, by the way, that addresses all of those things, has taken us, because we're community-based, took us a long time, but we've reached evidence-based intervention status. We've become a Debbie, so to speak, similar to Sister, a diffused evidence-based intervention at the CDC. And we know that we can be effective with an intervention that's created by women in our communities, delivered to women, led by and delivered to women in our communities, that also not only deal with it from that holistic perspective that you were talking about, but also deal with it from a rights-based perspective, because you know, we don't spend enough time talking about our health and our lives in terms of a human rights framework. So we add that to it.
Excellent.
But here's the challenge, and I'm talking straight to everybody now. That here's the challenge is that we are in an era where you're bumping up against a tough economy and public health that's being driven by science that says, not only do we have to believe in the science, but we have to believe in science that shows us some
Certain
level
outcomes.
of efficacy and economic cost saving, right? And to assume that the best practices are going to be the cheapest practices is completely misguided and misdirected. And so right now, you're sitting here talking about sister, I'm talking about healthy love, neither of which are interventions that our Centers for Disease Control will continue to fund. And so for Black women and women in general in this country, the interventions that we have are reduced to almost nothing. And so that makes us look at what we have in the community, but it also makes us start looking at what are some of the other things that will add to the behavioral stuff that we've been doing for a long time. So how are we talking about what pre-exposure prophylaxis or PrEP means to women? What are we talking about what treatment as prevention as a new science means to women? Or post-exposure prophylaxis, which is all new science in the last several years that hasn't reached our community and how we talk about it.
I think it hasn't definitely been framed for Black women in particular. The marketing has been towards, and it's validated towards the Black gay men or men who have sex with
for good reason.
For good reason.
Really good reason.
So I have to close this conversation. You know, I'm getting the, not just the, I'm getting the. But unfortunately, you know, we can't talk about this in 30 minutes. You know, it's big. It's big for us. It's big for us, our community. It's big for us as Black women doing the work. Because one of the things I want to throw out is, what does it mean for us as Black women doing the work? But we'll get that, you know, at the next time. So I want to thank all of you, each one of you, for being on this panel. And thank you for what you shared, the knowledge that you shared, and the passion and commitment that you have for doing this work.
Thank you.
Well done, Chioma.
Thank you. Thank you. Until next time. We'll be here next year.